Okay, well, there is our notification to get started. Thank you, everybody, for joining today's early intervention echo. If you've not done so, please take a minute and put your name and contact information into the chat. We are recording today's session. It is stored on our Canvas page. If you don't wish to be recorded, just disconnect from the session, and that would be sad. So please just stay right on here. If you also have a minute and you want to turn on your cameras, take a minute and turn on your cameras. It helps our presenters as well as all of us put names with faces and just get to know each other a little bit more. Echo is an interactive community, so that's where it's important to know who's on our call, where we're from, why we asked you to change your contact information. If you have any questions that you want to ask throughout the session, please go ahead and either raise your hand, put them in the chat. Bailey and Kurt will help monitor that. So they will ask those for you or come off. Let us know that you have a question. I'm going to always do a plug for our case narratives. That is a great way to just solidify information or get feedback from your amazing colleagues on the call that would have some information on how you can help a participant or a client that you're working with. So please consider to send in a case narrative. As always, we are talking about individual privacy and some sensitive topics. So make sure that you don't say first or last names or give any identifiable information. If you have any questions about it, you can always reach out to one of our amazing hub members. They all have an asterisk in front of their name. If they didn't before, I just reminded them to put an asterisk in front of their name, so they will now, but they would be glad to answer any of your questions. If you've never joined a Echo session, welcome to your first one today. A components of Echo is that we do have a didactic speaker, a case presentation where then we will do small breakout groups to provide recommendations. We're hoping that we're also building that community of practice and professional networking so that if you hear somebody say something that you want to follow up more with, you can always reach out to them on the Canvas page or reach out to Early Echo and we'll make sure that we connect you guys. With that, if you've not renamed your profile, please take a minute to rename your profile. You can do that by clicking the 3 dots or changing it down by the participant name. Again, how to raise your hand. But if all else fails, just put your contact information or your question into chat. And like I said, Bailey and Kurt will monitor that for us. We do send out a credit for attendance if you fill out the surveys. So we will be dropping the survey link into the chat throughout today's session, as well as it will be emailed to you after today's session. And that's how you will get a credit for attendance or a certificate of attendance. Canvas is where we store all of our information. So if you do not have access to Canvas or you would like that, please email earlyecho@usu.edu to request access to our Canvas page. Case studies, again, is the best way to hear information, get information about families that you work with. So please consider to do that. You can reach out to Early Echo at aggies.usu.edu or Kate Bennington, another amazing hub member, helps facilitate those for us. So you can also reach out to Kate Bennington. While we're waiting, I'm going to introduce our speaker today, but if you have not followed us on all of the social media, please take a minute to do so. We share really useful information, things that presenters or participants on the call share with us, as well as information about our upcoming sessions or our current sessions. I'm really thrilled today to have Dr. Debbie Bilder come and present to us about the URADD and autism statistics. So I'm going to stop sharing and turn the time over to her.
Thank you. Can you guys hear me okay?
Yes.
And I am in the doctor's lounge at the University of Utah Hospital. So if you do end up hearing background noise as far as like other voices, I'm kind of in a separate room, but if it is, I do have these, so I can put these in, just let me know. I think we'll be okay, but I want to let you know I've got a backup plan. So I will be presenting on the Utah Registry of Autism and Developmental Disabilities. URADD might be how you've heard it. And then an extension of URADD funded through the Centers for Disease Control and Prevention, Utah ADAM, Autism and Developmental Disabilities Monitoring Network. My background, I'm a pediatrician, a child psychiatrist, and a general psychiatrist, and a professor at the University of Utah. And I split my time between doing clinical work in individuals who are severely affected by autism and doing research as well as public health work, which is what we'll be talking about today. So I want to make sure that at the beginning I give a special thanks to Amanda Bakey, the PI of the Utah site for ADAM, and also our director of URADD, for sharing her slides with me. 80% of these slides started with Dr. Bakey, and I may have tweaked a little bit, but she really has put a lot of time into the slide deck, and I thought there was no need to reinvent the wheel. These are my disclosures. I do consulting for companies that produce pharmaceuticals for individuals with single gene rare neurologic conditions. It does not overlap with what we're going to talk about, but just for full transparency, I always put this in here. So we'll be talking about the registry, Utah Registry for Autism and Developmental Disabilities. Many of you may have heard that as URADD. And then we're going to kind of then expand to the CDC's Autism and Developmental Disabilities Monitoring Network and Utah's participation over the years, off and on in that program. Then I'm going to talk about specific results that we have across the network as well as Utah for prevalence among 4 and 8-year-old children. And then my particular area of interest involves co-occurring mental health conditions among our autistic teens. And I'm going to just share some preliminary information that we've been able to glean from the last 2 study years that are still working their way through the process at the CDC, but I want to have an opportunity to discuss what we're working on in that regard with you guys. So rather than go through an introduction of autism, I'm going to assume you guys all know autism pretty well. So I'm going to jump in, but if you have any questions, please interrupt me. I took those slides out of Amanda's deck. But it is a very heterogeneous condition. Wonder, well, what causes autism? I'll get asked that question not infrequently. And we really don't know. It's definitely clusters and families for many affected individuals, certainly not all. About 10%, there's a known genetic cause, but the irony of that is that for those individuals who do have a single gene abnormality for which they can attribute autism, it's much less likely that it runs through their family than the families of individuals we cannot identify a single gene. And that's likely because a gene that has that degree of impact on neurodevelopment is unlikely to be passed from one generation to the other. Many genes, when we do find single gene abnormalities that are associated with autism, they're often related to epigenetic changes, meaning we have our genome that we're born with, but then there's changes that happen to the genes that we have as far as turning them on and off that relate to our adaptation to the environment around us, basically. And it's those genes, not only those genes, but those genes definitely make up a decent component of those that we identify as associated with autism. In addition to being interested in mental health conditions among individuals with autism, I'm also really interested in prenatal risk factors. So it's not cause and effect, it's risk factors, it's associated conditions. And particularly, many prenatal risk factors are related to prenatal stressors, maternal stressors, such as inflammation, infections, other types of inflammation, maternal metabolic conditions like diabetes, hypertension, and even maternal stress, particularly in that second trimester. But like I said, you don't know cause and effect, but it does seem to have an association. As what I'd like to do is I'd like to understand these environmental factors so that we can identify it and really be able to improve the health of the mom and health of the baby, during this critical time of their development. So, why keep track of autism? Well, it really is important to understand what the needs of the community are, what services are needed. If you don't know how many folks are going to need to be served, and what the characteristics of those individuals are, it can be very difficult to advocate on behalf of individuals affected by autism. And then also, and this is kind of where I think Janelle and our team at Utah ADAM are really going to be working a lot together, is understanding who's accessing these services and who's not accessing these services, or maybe who may seem somewhat delayed in being able to access services that we know will help them with their skill building and help them with their working towards independence. Also, where awareness may be lacking. So this is us, Utah, and we're going to talk about epidemiologic studies of autism. And it actually first started here in Utah. We were the second study in the US. We were the second state in the US to have a study that looked at the epidemiology of autism, and that was back in the mid-1980s. So you could imagine at that time, it was, it wasn't the sophisticated approach that we have now, but it was definitely far more evaluation of individuals. It was population-wide for that time of individuals less than 25 who were suspected for having autism spectrum disorder. They did multi-level ascertainment. So if you had a previous diagnosis, if someone, a family member did voluntary referrals, school and health officials would refer individuals to the study, just case finding in the field. And then in addition to doing an in-person evaluation for some of the individuals for whom it wasn't clear, they also did a retrospective chart review. And this was based on DSM-3 criteria. And as you may be aware of, the criteria at that time, back in the mid-80s, was far more stringent, far more narrow. And so it's not surprising that the prevalence also was much less than what you would expect now, about 4 in 10,000. There was a much higher rate of intellectual disability co-occurring with autism. It was about 66%. Male to female ratio is about where it is now, about 4 to 1. These individuals clustered in families, about 10%. And then there are also individuals with rare genetic disorders that were identified and subsequently, recognized that these conditions are associated with a higher likelihood of the individual having autism. I also want to point out that back in 2012, we reclassified all of these records from this early Utah study of those who had not been identified with autism. They were distinctly defined as not autistic. And we went through the ADAM methodology, which we'll talk about in a moment, but it's the CDC methodology for classifying a child with having autism. We went through that and we ended up identifying 69% of those who had been deemed not autistic as actually meeting today's case definition or ADAM definition of autism spectrum disorder. Interestingly, and this was, in the 2012, if you think about it at that time and you think about DSM-4 TRs on which it was built, the case finding was built, the general thought was, well, this really broadened the net. We would recognize more individuals with more ability than those who were identified in DSM-3. In reality, who we identified with that new group actually had a lower mean IQ than those who originally identified. So I think the only study I know of that looked at the impact of DSM-4 TR and was able to see its impact on even those with less ability, when there's a lot of discussion going on about broadening it among those with more ability. So it was across the board really when when the second to last change was made. So going on to just URADD. So URADD, our registry, was established in 2003. A few years later, autism and developmental disabilities became a reportable condition in Utah. It's part of our health code. This is a program, even though it's contracted with the University of Utah, and I'm the principal investigator of that program. It really is run by the Department of Health and Human Services. Like they are my boss, and we answer. And I feel like I answer to them, and that makes sense to them too. It's within the Bureau of Children with Special Health Care Needs. We have a very long-term collaboration with the Utah State Board of Education, and there was also legislation passed, a few different pieces of legislation that supported URADD's ability to access educational records but families do have an opportunity to opt out. So their families are known that, we will be looking at records, and they're given about, a month or so to respond to the Department of Health and Human Services, just to say, no, we don't want to be part of the we don't want to share educational records of our child. And then we won't even know that they have educational records. But it's an opt-out rather than opt-in, which I think ultimately we were concerned, well, will this change our numbers? And I don't think appreciably it's impacted our ability to measure autism here. So it ended up, I think, being a win-win for our families who are particularly concerned about privacy and our need to understand the prevalence of this condition in our state. And then, like I said, it's population, public health, state, population-wide, and this is a statewide initiative. So we use the statewide information. It's administrative data, and we'll talk a little bit more about the difference between that and what we do with the CDC, but it's administrative data, and it's been used frequently to inform public policies, to educate stakeholders, to plan for autism and other developmental disability related services. We've really facilitated community awareness and supported others as they facilitate community awareness by providing them numbers that they would find helpful as they educate others. We have also worked hard to increase community access to screening, and our efforts are to, our purpose is to lower the age at which a child is first diagnosed with autism and a developmental disability. We'll speak more to that at the end of our discussion, at the end of this. And then also, in particularly my interest as a physician, is just understanding the causes. What are contributing factors to the development of autism, and what associated conditions co-occur in individuals with autism more commonly than those who do not have autism, particularly as those with language can teach us a lot about their experience with autism, so that for those who don't have language, we can understand better what they may be experiencing as well. So I just want to kind of go, this is our, data linkage. Like I mentioned, we link with school IEP, Individualized Education Program Exceptionality. It's an opt-out, so only for those children for whom their parents did not opt out. And we will we'll start with just the knowledge of who has an IEP and what the exceptionality is. And if it's autism, then in Utah, that will categorize you within our registry as having autism's spectrum disorder, autism. We can subsequently, as part of our CDC study, which I'll talk a little bit more about, have an opportunity to look at records and understand better autism for that individual. But even just on a basic URADD administrative data level, just knowing who is served by the schools with autism helps us understand the presence of autism.
I think everybody's phone is just making this huge buzzing. So
okay,
everybody.
Okay, are we good?
Yep, I think we're good.
And then, of course, we have health diagnoses, primarily from our two largest healthcare services in the state, Intermountain, the University of Utah, but also from our mental health, and other developmental sites around the state as well. We also link with birth certificate data through the Utah Department of Health and Human Services. And over our last funding cycle with the CDC, we were able to develop a formal collaboration with the Division of Services for People with Disabilities, so that we can further expand our understanding of the presence of developmental disabilities, as well as understand better how those individuals receiving DSPD services may be similar or different than those in our community who might qualify but are not receiving those services or on their waiting list. And then all that comes into URADD so that we can understand autism better in our state. So then there's the ADAM network. So when URADD was started, it coincided with us also receiving grant funding from the Centers for Disease Control and Prevention's Autism and Developmental Disabilities Monitoring Network. This is our current network across the state. So we have been funded again. Thank you very much, Janelle, for supporting our efforts. And for this study year 22-24 study years. And these are the sites. You can see there's a color scheme to this, in which you can see us, we're in pink because we're tracking everything. So we're tracking the 4-year-olds, the 8-year-olds, and the 16-year-olds with autism. And also we were recently funded to track cerebral palsy as well. But you can see there's now 16 sites, and it includes the territory of Puerto Rico, which I'm really excited about. For Utah specifically, really since study year 2010, so we were involved in study year 2002 with the ADAM network. 2008, it was kind of a small pilot study. Then 2010, 2012, 2018, 2020, like I said, we're funded for another 4 years. So it will be 2022 and 2024. So off and on, we've been part of the CDC monitoring network. And when we're part of this network, we're given additional funds to go beyond administrative, like we currently do, and actually look at individual children's records and do chart abstraction to clarify the presence of autism, as well as understand the presence of co-occurring conditions, the timing of autism, diagnosis, even certain, like I said, associated conditions, intellectual ability, various other aspects that help us understand autism, understand service access, screening, when were they screened, when are they getting access to early intervention services. Since 2010, we have had this 3-county surveillance area. So it's not statewide. It's 3-county surveillance area. And so it's Salt Lake County, Davis County, and Tooele. So we have a rural county in there. Back in 2002, instead of Tooele, it was Utah County. But since then, it has been these 3 counties. And you can see just, over the years, initially it was 8-year-olds. Then the network wanted to pilot 4-year-olds, and we were given an opportunity to be one of those pilot sites. Then 4-year-olds became every site along with 8-year-olds, and they piloted 16-year-olds, and we were given an opportunity to be one of those pilot sites. Now, most of the existing sites, there were a bunch of new sites coming in, but the existing sites many of them are also doing 16-year-olds as well. And now we're piloting cerebral palsy. So it's just, when you're a pilot site, it's really fun to be one of the pilot sites, because it's really about learning and realizing it's not going to be perfect. This is a process. We're learning for the specific age group, or now we're going to put the specific condition. What do we need to understand that's the same and different to do a good job on being able to measure the prevalence? So I do want to speak briefly about co-occurring intellectual disability. As you may be aware, with DSM-5, the latest diagnostic manual, the diagnosis of autism, even before DSM-5, it needed to rely both on adaptive functioning being impaired, as well as cognitive functioning being impaired. And then with the DSM-5, it really kind of leads with that adaptive functioning impairment in regards to the level of intellectual disability. It also requires the cognitive part. ADAM has always focused on the cognitive part, the IQ, and I think part of that's just because what we found is that not every child who's identified with intellectual disability gets an adaptive test, and it turns out those who don't are often those of lower socioeconomic status, minorities, and we recognize that if we were to require both adaptive skill and IQ testing, then we would inadvertently be excluding those individuals who are among the more vulnerable in our population. So we're still defining this by IQ, but it's with acknowledgement that our world has moved forward and progressed to adaptive functioning. This is just where we're at, and trying to be consistent with monitoring and capture those folks who otherwise wouldn't be captured because they don't have adaptive functioning tests. And so now let's jump into our results. So we're going to be talking about the 2020 study data. So the same surveillance sites were funded for 2018 and study year 2020. And you can see we were doing surveillance on the 4, 8, and 16-year-olds, as well as 10 other sites, at least for 4 and 8-year-olds. We were one of 5 sites that was doing surveillance for the 16-year-olds, and that was pilot at that time. But you can see it's diverse across the U.S. in different communities. It is not intended to be weighted to proportionally to represent the U.S. in that it's not like each community is selected to have this proportion that's reflective of the U.S. proportion. So with a grain of salt in that regard. It's so when we come up with rates, that's as good as we can get, but with the recognition that it's not like each community is perfectly aligned to have the right ratios of various different racial, ethnic groups. And so I do want to speak to some changes that happened along the way as we've identified rates, because there have been changes in the rates that you'll see reported. And I think this is an important recognition, is that up until study year 2016, you would do a retrospective chart review. You'd abstract medical records, school records. They put a composite record together. There was a clinician reviewing that record and using a very, very specific algorithm, phrase by phrase, going through it, coding it, really phrase by phrase, to determine whether the child had the number and pattern that was necessary to meet criteria or case definition for autism. And then you'd say, oh, that child has autism. That shifted starting with study year 2018, where it's now entirely administrative in regards to determining whether that child has autism. And so you need to have really community identification, whether it's a diagnosis, whether it's an ICD code, whether it's in a special education exceptionality of autism. That's how you're then defining whether the child has autism. We still do a records abstraction to understand better how is that child experiencing autism? What are co-occurring conditions? When was this first recognized? Did they get early intervention? So there's all of it's still that same process, but it doesn't require the child to be able to have all the components necessary within their documented records to be able to call that child autistic. And I think that impacts how we measure autism, not just in numbers, but also in distribution of kids that we now recognize as having autism across the US. So, like I said, the case definition, it's whether they have a diagnosis, whether they have a special education exceptionality for autism, or whether they have an ICD code for specific to autism. One of those three. Many have multiple. Most of them have multiple, but they need to have at least one of those three. Just among the 4-year-olds, we also created a category for suspected. They didn't meet the criteria as spelled out, but there was a suspicion of autism reported in their records. So what we found, and so this is across, this is across the years. And so you can see back in 2000, which we hadn't participated in, it was 1 in 150. And then 2002, we did participate in, it was 1 in 150. And you can just see this gradual rise in rates. And really, if you think about it, I remember when we were when I was part of a press release, or at least attended a press release. I don't know if I actually got to say anything. I was just a part of the team. Oops. Let's see. When it was 1 in 150, it was really thought to be a rare condition. Like I said, when we identified it in the mid 1980s, it was considered 4 in 10,000. And so it really just hit, the US. With wow, this is not as uncommon as we thought it was. And then it became then of course awareness, the number, our ability to measure, whatever other factors could have been part of it, it just continued to rise. I want to just indicate right here is when the DSM-5 came into play in regards to defining case status, and that was for 2014. As you know, the DSM-5 has also broadened, just like the DSM-4TR has broadened our understanding with autism. I think DSM-5 has as well, and so that also could be reflected. But look at this big jump right here. This is between study year 2016 and study year 2018, and I had mentioned that what changed at that time was administrative prevalence. So here URADD has been doing administrative prevalence all along. And I can tell you that in our state, even though we had 1 in 50 back in 2002, about 10% of those kids who were identified in Utah were only through our records review process. They had not been identified in the community, but we identified the number and pattern necessary to meet criteria. As we approached these years, and really for us, it was, study year 2012, 2010, we really started, once again, comparing what are we finding through our records review and what are we finding through administrative, and all of a sudden they practically became one. Like it was unusual to identify a child who had not already been identified in the community. And so I think that also was reflecting the awareness that was growing. But now that we've moved to administrative prevalence, where we don't need to be able to access the child's record if we know they have a diagnosis. The child doesn't need to have documented in their record, all the numbers and patterns that are required for an autism diagnosis. Rather, they just need to be acknowledged or recognized as having, getting served as if with the autism diagnosis. And now you can see this big jump up to 1 in 44 and 1 in 36. I actually think, we're going to talk about this next, but I think it's had more than just an impact on how common, we're measuring autism. Not yet, we'll get there, but I think it's also impacted something else too. But this is just looking across the different sites, and you can see for Utah, You just, you could see for Utah, and I can't, I know we're right next to Georgia, and I can't see the bar because it's in my way. There we go. So Utah's right here. We're right next to Georgia, and so this is where our rates were. And so for a long time, as some of you might know, we were really kind of up here towards the higher rate end, and all along, really from early on, from 2008, I mean, the schools have always worked with us. At that time, I think it was health code. We've just had access to a nice, thorough understanding of the degree to which autism affected our community. And I think other sites as well have been able to kind of catch up to those rates as well. And so we're less kind of out there in regards to our own rate, or right next to New Jersey's. In addition to this, and California joined our study year in our ADAM network in 2018. Even though this is 2020, it's very similar. You can see California's rates are way, higher than everyone else's, and of course that's going to bring up the overall rate as well. But this is color coded, and the color coding really has to do with the way in which I identify the case. And so these individuals in green, they had an autism diagnosis. And then those who did not have an autism diagnosis, but in the least had eligibility in schools, are in the blue. So those in the blue did not have a diagnosis, but they did have eligibility. Those in the purple didn't have eligibility at school, didn't have an autism diagnosis, but they had an ICD code. So that kind of also gives you a sense of how the case status was composed across the different sites. Okay, this is really where I wanted to speak about the changes, I think, and the impact on our numbers. This has to do with the difference that we have in recognizing the prevalence of autism among individuals of minority races and ethnicities. It used to be, and you guys might remember this, where it was your white non-Hispanic child who had a measurably higher risk of being diagnosed with autism. And for study year 2018 and 2020, that has reversed itself. Now, across the network, it is those who have Asian Pacific Islander background, those with Latino background, those who are Black. They have a significantly higher rate of autism measured in the CDC network than those who are non-Hispanic white. And I actually do feel like this also reflects our administrative prevalence. Like I said, it's, in order to have met the case definition before, it required that you had everything documented in your medical record. And it may be that some individuals of minority or ethnic minorities or racial minorities may not have access to the same degree of healthcare, or the same access to providers that would document all of that, like those who are non-Hispanic white. And so we've seen this shift, and it coincides. I know with awareness, and I know there's been a lot of work being done in minority communities to increase awareness, but I really feel that the administrative prevalence component of this has helped us understand much better the presence of autism among communities that may not have access to the degree of healthcare that the white non-Hispanic children did. So for Utah, just so you know, for our specific numbers, in the 4-year-olds for study year 2020, we did have a higher rate among those who were Latino, but we didn't see that for 8-year-olds. And our numbers for other minority groups are not large enough for comparison. This is another piece kind of to the same thing, which has to do with, another way of looking at racially and ethnically, just how things are changing over the years in regards to prevalence. With the white non-Hispanic children now here across the network, and then children of minority or ethnicities or race being measured at a higher rate. So I also want to speak to this because it's across the whole network from a mean perspective, but not at every site individually. But definitely, I think Utah had the most prominent findings, and that is another reversal, and that has to do with health code income. It used to be that those who had you could see here back in 2010, and this was done by Maureen Durkin in Wisconsin using ADAM data. You can see that you saw higher prevalences across these 3 different ways of looking at socioeconomic status, whether it's mean household income, percent of moms with a bachelor's degree, percent above poverty. You can see these significantly higher prevalences among those with more financial means. And now in 2020, it's the opposite. This total has to do with across the network. So still those with the highest means have the lowest, or significantly lower than the other two groups. But look at in Utah how clear it is that we are identifying far more individuals with in the lower socioeconomic status than in the higher before. And once again, that may also be impacted potentially by switching to administrative prevalence, as I was speaking in regards to minority status too. So this is just looking at the co-occurrence of intellectual disability. And you can see that males to females, it's not unusual to see a higher prevalence among females, as you see here, than males, as far as the percentage. And then you can also see race, ethnicity. Babies who are children who are Black, non-Hispanic, have a higher risk of having co-occurring ID when they have autism than a white non-Hispanic babies, and even Hispanic babies. Because I'm also very interested in this particular group, those with autism and intellectual disability. As I had mentioned a little bit earlier, these are my people. These are the folks I really love working with from a clinical perspective. And I want to understand better from a birth risk factor perspective, why is it that these babies are at higher risk to have co-occurring intellectual disability in addition to the autism? And so something I've been looking into and working with the CDC and looking at various birth risk factors. I can say that I think a major factor in it has to do with the risk of prematurity among babies of Black moms. And you also see, higher rates of cerebral palsy. So I think we're just going to understand this better in the network as well, now that we're looking at cerebral palsy too, which is another area which appears to be those of minority backgrounds are at higher risk. So looking at the 4-year-olds, so this is the rate, as I showed you before, but this is for the 4-year-olds. And you can see us all the way here once again, and this was the case in 2018. In 2020, we also had the lowest rate among all the different sites in regards to prevalence of 4-year-olds. So it was a higher rate than 2018, but it was still lower than the other sites measured as well. And then once again, California is just right up there. California attributes this, just so you know, to the very intensive screening program that they have. So this is in San Diego County. And so this is in the area of San Diego, and they have for many years, I guess over 20 years, they've had a very intensive type screening process with the pediatricians, and then a quick referral to assessment and diagnosis and treatment. So they attribute their high rates to how early their kids are accessing diagnosis and then intervention. I can also tell you that they also have the highest rate in which kids were subsequently ruled out as having autism. Later on, I think it's like 25, 28% are subsequently ruled out, where Utah's probably like, I don't know, maybe 5%. But it still doesn't make up for that, double difference, like maybe a little bit, but not entirely. So just more to understand and recognize the importance of early recognition. But I also want to speak to this slide. And this slide from 2020, looking at our 4-year-olds, looks at not just prevalence, which is the brown bar, but also of confirmed, but also suspected. And take a look at this. You can see the 3 sites, Utah, Arizona, Arkansas, that had the lowest measured confirmed prevalence appear to have the highest suspected prevalence. And then when you kind of add the numbers together, it all kind of evens out, of course, with the exception of California. But I think this really speaks to really why your job is so important in regards to early intervention. Is because these are kids who are suspected of having autism, but they don't have a confirmed diagnosis. And even though, yeah, you can, of course, have early intervention services, through IDA Part C, as far as having like ABA, autism specific therapies, to be covered by insurance, it needs to have a confirmed diagnosis. And so when I look at this, I really see this as a call to action for us. I'm not saying all of these who are suspected are going to be diagnosed, but I suspect, looking across the board, probably a lot of them. And it speaks to just the ongoing need we have in our state to get from, suspected to diagnosis, so that kids can have opportunities to work on those skill building type of therapies when their brain is really most able to learn and respond to it, like their neurotypical peers are learning those skills at that time. And so this is another one of Amanda's slides. And initially I'm like, oh, look at this. We're doing such a great job reducing the age at which children are identified with autism. I thought we weren't going anywhere. And then I look at the numbers, look at these. So we, since, over the last, over 15 years, we went from 57 months across the network of a mean age of diagnosis, or median age, to 54. Like, so this looks great because of the scale, but I mean, we're really talking about the difference of 3 months, over. So I'm glad we're reducing that age, but we obviously still want to be able to do more than this. Although, to be fair, and this is another would have made slides, and this also was published in Kelly Shaw's paper, with the CDC. Children are 4 times as more likely to be diagnosed in 2016 at 4 years of age than they were in 2002. But then, of course, if you recall, the rate's 3 times higher as far as your likelihood of, in general, of being diagnosed. So, I mean, I feel like, I think it's some ways it makes you feel better, but I think still in the big picture, we're not, we've got a lot of room to go in regards to getting to where we're trying to go and getting these kids recognized early so that they have an opportunity for skill building and supports. This is over across the network. This is the prevalence by age. And so this is looking at our 4-year-olds in the yellow, and then among the 8-year-olds at that age. So you can see across the network, it's looking that they're getting diagnosed earlier, but in Utah, it's pretty, I can squint. It looks pretty similar to me. I can't say that we are as far along as the others. So as far as co-occurring mental health conditions, I had mentioned that this is an area where I feel very passionate about, and I hope it's okay that you're going to listen to me talk about it. Not for very long, but co-occurring mental health conditions, they affect, they are very common in those with autism. We can treat them just like we can in neurotypical individuals. It contributes to the stress of their own lives, to themselves, of their ability to be adaptive, to be able to learn in the most, the least restrictive setting. To be able to be comfortable out in the community and be able to engage with those in their community. And we also see a higher use of psychotropic medication use. And from my perspective, I feel, well, if it's directed towards a specific mental health condition, because we know they're at higher risk, that makes sense to me. What concerns me is when it's not directed towards something specific, it's when it's directed towards agitation or aggression that is assumed to just be part of autism, which, by the way, it only affects a minority of individuals with autism, like at best, like 30–35% of individuals with autism, even though it's discussed as if we're synonymous with autism. Then, and I think that's where it's important to give pause and think about when an individual presents, who's autistic, who presents with agitation, that they may have a reason to be agitated like the rest of us. They just may not have the language to describe it. And given that there's such a high frequency of mental health conditions in this population, it's important to think about mental health conditions as well as medical things that can be contributing to their agitation, rather than just having, diagnostic overshadowing and attributing it to the disability instead. So I want to give you a sense to compare. So these are population-based studies that are in the literature right now that include adolescents, autistic adolescents. And you can see these are locations. So Sweden, Kaiser, Harvard. So it's kind of like on either coast. And then KPNC is Kaiser Permanente, Northern California, and then Canada. So you can see the general rates of like ADHD that are measured. And you can also see this is only through ICD codes, billing codes, because that's really what we have available to measure prevalence, on a population level. But for those of you who work with this population, particularly those who are school age or maybe a little bit older, these rates are kind of looking a little low to you. Now, you might think, well, but if I'm in a clinical setting, of course, I'm going to see a higher percentage of those who are clinically affected. But even so, even as a clinician, it's like when I look at these rates, I'm like, that's just not, no, like really, we really think of these as affecting more affected children than what these numbers show. So when we measured it in ADAM, and this is something I'm leading our network and looking at in our 16-year-old data from 2018 to 2020, what we looked at was not just billing codes, but billing codes pulled at 2 different time points, at 8 years of age and 16 years of age. So all of these other ones are one point in time. So even though they theoretically will take the lifetime, prevalence of that condition, because they're looking for all the billing codes from that time backwards, in reality, they're just not necessarily going to access those earlier codes as readily as you would if you were to measure, as you were to pull it at different time points. And plus in ADAM, and even, in registry, we're pulling from different health sources, and many of these are just one single health source. And so you can see the rates really, actually, as a clinician, make far more So, I mean, about half the kids with autism are affected by ADHD, a little less than that, anxiety. I think depression, is 18%. And if you look, even though bipolar is 3%, 3.4, relatively small, that is still much higher than in the general adolescent population by probably threefold, if not higher. And then psychosis, just 1%, but still much higher than in the general population. And if you were to look at populations of kids who are identified with, childhood bipolar or early onset psychosis, you will see a disproportionately large group of individuals, of children with autism in that group. They're far more represented than you would expect with their current population prevalence. And then you can see from antipsychotic use, we looked at this as well, because that was an interest of mine, because my interest is, antipsychotics are appropriate for emergency situations. And then of course for bipolar or psychosis, because that's what we would use in a neurotypical population. But just for agitation associated with autism, I just think that there are other options once you get past the emergency situation. This gives me a kind of a litmus test of what's going on. And we're about 16%, which is not too far off of 20% that was measured in the Kaiser Harvard study. And this looks at, so I mentioned, so if you look at the red, like this would be, if we were to measure this, like all those other studies did, one point in time, at 16 years of age, this is what we would have gotten, that rate. But look across and see the contribution of records review. First of all, looking at 8 years of age, looking at 16 years of age, combining it. I mean, you can see how by accessing these records across time from multiple sources, how it gives you a much more thorough sense of what could be there. So, in summary, prevalence has increased, autism prevalence has increased over time. Since 2002, we are seeing less disparities, far less, in race and ethnicity and socioeconomic. In fact, if anything, there's a reversal. And as someone who's also interested, not just in co-occurring conditions in our teenagers, but also in maternal conditions that can increase risk of health concerns to mom during pregnancy and to the baby's development, I think this really changes, it's a real shift. I mean, when we were looking at this back in the 2000s or early, 2010s, we had a partial picture. We were not seeing this across the board in a population-based level. Now, I think we're finally having an opportunity I think we need to revisit this and understand this better now that we have a better glimpse of who exactly is affected, understand risks occurring during pregnancy that could affect that pregnancy. And then schools are absolutely critical. We feel quite grateful for the relationships we have with our schools here. And then of course we saw that the variability site by site to prevalence and how this impacts overall prevalence. And then I do want to just remind you that our teenagers who are autistic, they do have a higher co-occurrence of mental health conditions. I think having autism certainly is a stressor. My particular interest is understanding the degree to which the underlying condition that lent itself to their experience of autism, how that could also be contributing to the risk for other mental health conditions. So it's kind of more my angle, but there's so many different ways of looking at this. I think the important thing is recognizing it's there and being able to recognize it in this population, making sure they have the care that they need to help them, because there's no reason why they wouldn't respond to treatment just like a neurotypical individual. So and then these are just, it takes a village. I just want to express gratitude towards so many different stakeholders in our community who make this possible, who use our numbers to help us be relevant. And of course, our team members who are part of collecting this data, understanding this data. And then of course, the Utah Department of Health and Human Services, which I need to update that. It's like Department of Health, but now Department of Health and Human Services. And then, of course, the other site PIs and investigators. So I should have told you ahead of time, I only have one screen. So if people have been raising their hands, I'm not intentionally ignoring you. I just don't see it. Or if there's questions in the chat. Now I can see Kirsten. But if you go ahead amongst yourselves and organize, I'm going to stop sharing so I can see you all better.
Okay, I just barely raised my hand right then.
Oh, good. That I don't feel so bad.
But I don't think other people were doing it.
Okay.
So first of all, I want to thank you for pointing out the stuff about the mental health. So that's going to be a great lead in for some of the things I'm going to talk about next month. So,
What
thank
is
you.
your discussion next month,
We're
Kirsten?
going to be talking about physical activity in autism.
Great. Yes, it is. It's very much a good lead in. Thank you.
So, but I did have a question. This might be a little bit off topic, but you mentioned that the male to female ratio is still about 4-to-1 or 3.8-to-1. And I know that's kids who are identified, and I know there's a
Right.
lot of talk going on about
Of
girls
course,
doing
yes.
differently than boys and how our tests are all
Right.
designed
Geared
for
towards, yeah.
boys, normed on boys, and all of that. So, do you have any thoughts on what
You know,
the real
I
prevalence
do.
is, or what's happening with that research there
Yes.
in terms of identifying girls?
I do. So first of all, I appreciate you bringing that up, Kirsten. Definitely my colleagues, you know, and Kirby, you know, many leaders in the autism world have recognized for quite some time that the way in which we identify autism seems to be biased towards males, and have made a tremendous effort towards considering how autism may present differently in females, and recognize it to be able to support them and help them understand themselves better too. And I'm very supportive of those efforts. I'm also really interested in prenatal risk factors. And there's also a part of me that, you know, so as a scientist, I have skepticism. Anyone who knows me, I'm an optimist, but I'm a skeptic when it comes to science. So like, okay, prove it to me. Prove it to me that it's just as common in females as it is males. And then I'll believe you. I will watch you and look. But my interest in prenatal risk factors really fundamentally has to do with the difference between the experience of female babies and male babies in utero when stress occurs. And so the placenta is sex specific. I know we don't think about that, but it's the sex of the baby. And we know that the placenta of the female placenta responds differently than a male placenta to stressors. I mean, opposite, they respond opposite. So that when a stressor occurs during pregnancy to mom or the pregnancy, the baby slows down their growth, like starts conserving, right? We do a good job with that. And, you know, and just slows it down a bit, while the males just keep on going right ahead. You know, they keep on growing, they don't slow anything down. And what it lends itself to is if a subsequent insult were to occur, they're obviously going to be more vulnerable than the female who's conserving. So as I look at this, and there's also some other things too about the prenatal environment that's different in regards to how males respond to females. Like I've had this skepticism. So I'm like, I want to see this play out. So I recently had it just like, so I'm kind of in the background wearing beige, because like I am all about understanding autism in females, like, but I really do believe there's a difference, just like Tourette. So I recently had a chance to see some folks present on this, and they looked at the early childhood population, and they looked at children over 20 years. And I won't be specific because they haven't published their data yet, but I looked at children over 20 years. You know, in early childhood, to see if there were any differences in the presentation between the males and females who were identified with autism, as far as like characteristics, like anything. And like they looked hard, like they expected to find something, they did this to find something, and they didn't find anything. And so I'm sure they're going to keep on kicking that, you know, down the street to try to figure out where are the differences. But part of me is like, yeah, I kind of was expecting that, but keep on looking, like keep on understanding it. So I think it's just a question mark. And the way you answer these question marks, Kirsten, is through a study like ADAM. Like it's got to be population-based. Now, yet this population-based study is relying on administrative data. But remember, we can then go into the charts, and we then look at the specific aspects of those different kids so that we can at least. So I think the particular study I'm mentioning isn't specific to ADAM. It's specific to their own program, which was a very extensive program they've been doing for 20 years. And so that's what we need, is like this combination of population-based as well as, you know, actively like recruiting in it and administering it. But I think there were many on the call who were surprised that didn't find anything. But I have to say, like, I'm still, you know, wearing beige in the form, like, well, I don't know, like, I'm thinking like there's different ways in which, like, I like it still makes sense to me that but I do hope that there's better, because clinically, I definitely will see young adolescent females who have autism, who have not been identified, actually have been labeled with like borderline personality or other types of things. And I'm like, no, she's autistic. And if we start understanding like that, you're going to really think differently about these behaviors. So like, I see it that way too, but across the population, we'll see. So boy, you got me on a really interesting topic there.
I know, and I was just gonna, I'm like, I need to interrupt you because I know
Right.
we could spend a lot of time talking
And
about
if-
girls
Yes.
and ASD. I'm gonna just take one more question. I know there's a lot of
I
questions,
apologize, you
but
guys.
Olivia has had her hand up. And I'm gonna let her do it, and then we need to move on to our case presentation.
Sure.
So my question is about identifying risk factors for autism in kids who have diagnosis like cerebral palsy or other genetic conditions. How do you differentiate, you specifically as a clinician, but also like us as early interventionists, how do you differentiate red flags or like signs of possible autism in kids like that?
You know, that is a great question. So when I think about autism, and I'm glad you brought up the genetic piece, I realize that there are those, clinicians in the community who kind of call this atypical autism when someone has Charge syndrome or some other type of genetic condition, and they also have autism characteristics, and they're reluctant to call it autism because it's the number and pattern. If you have the history, you have the number, and you have the pattern, like you have autism as far as I'm concerned, and you would benefit from intervention. I think the challenge there is when someone doesn't have language, because so many of it's communication. So what do you do when they're blind, or what do you do when they're deaf? Like, so I can't give you like a prescriptive, this is how you do it, but I can tell you, I just keep in mind, it's a number and pattern. If they have the characteristic, and remember, it's not just one little area. It's social, it's communication, it's repetitive behaviors, it's sensory. Like if you see it across the board, even though maybe one piece of it you can account for a certain disability, if it's there, I have no issue calling it whatsoever, and then ensuring they have access, advocating for them to have the supports.
Well, Dr. Bilder, thank you so much for your time. I know that I have dropped in the chat the ADAM network through CDC, as well as Utah's specific snapshot data that you have.
Thanks. And Pat, can you email me? Because I would love to, we're on the same page. So can you please email me so we can have a conversation about this? Okay, thanks.
Awesome. Well, thank you so much for joining us.
Thank you. Bye, you all.
Bye. Good luck with the rest of your day.
Thanks, you too.
Okay, so Kate Murphy, I've heard you guys have some internet issues at the
I think we're
university.
good now.
Okay, so
I've been on it was kind of rough to start. She was breaking up a bit and then it kicked me off, but I haven't had any trouble since. So who knows?
Okay.
Maybe they got figured out.
Okay.
My phone's ready just in case. So
do you want me to share for you, or are you going to share?
that would be awesome if you could share it. I don't have it up. I'm ready.
Okay.
Okay. And the parent of my kiddo is on this echo too.
Okay.
So
I just moved it. Sorry. Okay, can you see it?
Yep.
Okay.
Yep. So this is me. I am with the Minot Infant Development Program here in North Dakota. And then so my case presentation is on a kid who I've had on my case load since about 21 months. It's a 30-month-old little girl with an autism level 2 diagnosis. She has received monthly occupational therapy consults since we did the evaluation, monthly speech consults since we did the evaluation, weekly home visits. I forgot to add that in. And then she also receives outpatient speech and outpatient OT. They kind of do it together 3 times a week. So at her 21-month evaluation, she had global delays. And then the following month, this appointment was already scheduled. She was diagnosed with ASD. And then she had PE tubes placed on June 23rd of 2023. And the audiologist noticed that there was a definite auditory disconnection at her follow-up. And the family is still waiting to set up a follow-up appointment through where the autism diagnosis was with a sleep specialist. And this little peanut needs a lot of sensory needs to function throughout her day. Her day is completely thrown off if she doesn't have that sensory input. Mom's primary concern is for her child to have a consistent daily and nighttime routine schedule while getting the proper sensory input, and for the family to have the resources needed to help get the sensory input she needs throughout the day. So whether it's a weighted vest or a compression vest, a swing, a trampoline, a chewy, because she likes to mouth some things. So she's very particular about the spoons she uses. So having that proper sensory spoon, just getting those resources for the family. So at her 6-month review, we had the goals of using words to communicate her wants and needs throughout her day, independently dressing herself to get ready for the day, regulating her emotions when playing with her siblings and mother, eating only food items and not putting, or to stop putting unsafe items into her mouth. She was over the age of 2, so we had a transition out of infant development and into the school setting. And then we wanted her to respond when told stop or no during playtime so she's safe, and to fall asleep in her own room and stay asleep during bedtime. Those barriers, lots of sensory inputs throughout her day. Needs a jewelry necklace throughout her day, and to be reminded to use it. She might have it around her neck, but she might see something like this, pick it up, put it under her mouth, and just remind her to put that in. Wearing a compression vest often throughout her day to keep her regulated. At 21 8 months of age, we completed a sensory profile. We have not done one since. At the time, she demonstrated a definite difference in the area of auditory processing, probable difference in auditory processing and typical performance for tactile, vestibular, and oral sensory processing. She had a definite difference in the area of low registration. Our OT indicated that her nervous system requires more sensory input than most children her age, which has been something we're coming up on a year here in December, and it's still, she needs a lot more input than most kids I've seen. And then I get the pleasure of every so often going to her direct therapies with mom and, seeing what they work on. So they are working on PECs as a main priority to help build her communication. So currently they're only working on more, as she's not really looking at more functionally. She knows that she has to take it off, hand it to them to get something in return. So just that simple, taking it off, handing it to the speech therapist, working on following simple directions, imitation of any sort, whether it's sounds or gestures. And then she recently mastered a speech goal for choosing between 2 named vocabulary objects. So that was really neat to see that she mastered one of her goals for speech. OT's direct occupational goals are working on all things functional plays, putting coins in a piggy bank, putting gears on the spinny gear, taking things out, stacking, pointing, like polka dot books with that index finger isolation, imitating of motor actions, scooping with a spoon. She gags with different sizes and textures of spoons, like not a fan of metal spoons, so found a Fisher-Price kind of flat and wavy spoon. Not flipping the spoon upside down when inserting it into her mouth, and then just getting that sensory diet that she needs. So whether it's a compression vest, the jewelry, joint compressions, a swing, all that fun stuff. And currently the family is on a wait list for their place for direct therapy for PT. Direct therapy recently hired another
Sorry, I put him on mute, Kate. Go right
Okay.
ahead.
The direct therapy recently hired another physical therapist, so hopefully they're gonna be start scheduling kids soon just to help with some of those needs. She's very motor driven, but she likes to tiptoe walk and everything like that. Oh, and mom just commented on the thing. I think that's who was talking. She is started PT, so. And kind of just a brief family culture. Family rents a home in Minot. Mom works a couple jobs, 2 older siblings and 1 younger sibling. The little girl attends Head Start Monday through Thursday, gets to be at home with mom on Fridays. Paternal grandfather lives in Minot and helps out and supports the family in many ways. And then I didn't put anything because I wanted mom to kind of ask those questions that she could get help on through this echo.
So
Go ahead.
Cheryl is the mom, right?
Yep.
Okay. Hi, Cheryl. Welcome and thanks for joining us. Do you have 2 or 3 questions you would like our group to provide recommendations for?
One, it just when the doctor was talking, it was very confusing because like they said, you know, one single race and more so female or male. Well, my child is a biracial child, so it's like where's like how do you calculate the data and you know that like I was just like when she was speaking, I was just trying to like, you know, figure out like, okay, so you take this percentage and this percentage and put them together, like because there's a big community of multiple biracial children out there that are autistic that weren't on that spectrum, you know.
Yeah, and I can certainly connect you with Dr. Bilder and answer that. I don't know that any of us on this call would be able to answer that since we don't have access to that data.
Yeah, and then another question, she was saying a lot of sensory input. So like you have OT working on some things, like her visual stimulation, like to get her to acknowledge you, like look at you. It's kind of tough. And then her like what would you guys do or can give me information on safety? Like she doesn't acknowledge like I got a security system. Like when we're going out in public, you know, I have a little book bag with a strap, but sometimes like she just has no self like safety outside of in the world.
Okay. So I heard to discuss about safety concerns, so acknowledging and some sensory around visual. Anything else you would like us to kind of brainstorm for you?
That and then she just seeks a lot of deep pressure. And I mean, I'm doing what I've been taught by, you know, a therapist with MSU and with her speech and everything. But yeah, that between pressure, like self-harm, like that safety, you know, just like answer all around, like whatever good advice you guys have to give a mother so that I could try to execute better for my child.
Fantastic. We will be having Cheryl pop in and out of the breakout groups. When we move to the breakout groups, please take a minute and turn your camera on. Introduce yourself to who's in your breakout groups. Kate, I'm going to have your group work on that different types of sensory input question. Pat, if you would work on different ways to work on acknowledging that. Heather, if your group would work on some sensory visual ones. Shelby, if your group would work on the safety concerns. And then Kurt and Kirsten, you are both in a group. And you guys can pick which one you want to work on with it. Hey, so we're gonna take a minute and do breakout rooms. Pat, you have one question?
You need to clarify acknowledgement of what? Danger?
Acknowledging them, so that responding to her name.
Attending.
Attending, acknowledging them. Yep. Okay, and like I said, take a minute, turn on your cameras, introduce yourselves. We will be popping Cheryl in and out of the breakout sessions. Kate, you have a question as well.
My internet just glitched right when you said what my group should talk about, so I missed what you wanted me to cover. I'm sorry.
Just different types of sensory input. So they mentioned the deep squeeze and okay.
Thank you.
Thank you. Kurt, you are in with Kirsten. So you guys should see that popping up and join those, and don't forget to assign a note taker, and we'll come back. Everybody, as we're waiting for everybody to join back on, if you guys, I don't know who you had take notes, I'm just going to call on the hub members and they'll be able to share one idea from your group while we're waiting. If you have not taken the survey, take a minute and complete the survey. Martha, you look so serious. There, fantastic.
Well, Martha was talking about being animated and excited during our session. So I think she just got tired, maybe.
She was also talking about being crazy, which I will vouch for.
She always is, which is why when she was so quiet looking, I had to say something. Okay, welcome back, everybody. We're just going to have each team or each breakout group say one thing. I'm just going to call on the hub member. So if you assign somebody else, you can let me know. So the first person that I see is Heather. So
yeah, Colette's going to share on behalf of our group.
All right. So one idea, Colette.
We had a PIP specialist in there and she just suggested really drawing attention to objects. And she had a really great idea of using painter's tapes or mats to draw attention down for things like stairs and transitions.
Awesome. Okay, Kate, your group.
Kate Murphy took notes for us, so I don't know if she wants to share one thing that she wrote down.
Okay, Murphy, you're on mute. So I saw you talking. There you go.
Okay. I was saying I just lost them, but I found them. Okay. I don't know where they saved them to, so now this is gonna be fun. We just talked about giving different strategies. So we have Mom in our group right away. But after Mom left, we talked about like since she's most regulated in the morning, talking about her sleep schedule and is there something in that sleep schedule that's getting her off, and maybe how she loves Cocomelon and everything to help regulate her more, something that's not so stimulating.
Awesome. Great. So Kirsten, your guys' group. You and Kurt.
I took notes, so I'll just share one thing.
Okay.
Well, there was one that we talked about a GeoBit when we're talking about safety, because we kind of got to choose. There's what's called a GeoBit, which is a tracking type device, and also letting neighbors and others or in the general area know if you see my child without someone else with them, that's a concern. Contact us as soon as possible, just to kind of keep track of the safety issues there.
Fantastic. And then our last group, Shelby.
We talked a lot about the GPS tracking device. just because I know, Kate, that we recently had the Project Find Safe awarded, that grant was awarded again, so.
Yes, I just actually sent Vanessa an email asking her about that, saying I have a family that could really benefit from it. So fingers crossed she gets back to me soon.
Awesome. So yeah, either like a GPS tracker or just like a bracelet that says, you know, I am autistic, if found, please call so-and-so.
What is that
program called?
Project Find Safe. I don't know who asked that question.
I don't either, but that's great. And then Pat just informed me I forgot Pat's group. So Pat, she's so Pat, share one idea from your group.
Okay, so unbelievable ideas that we got, but I think the one thing I want to share is they talked about a woman called Laura Mize, M-I-Z-E. She's a speechy who has a podcast, Teach Me to Talk.
Yeah, that's a great one. Well, fantastic. We, Cheryl, just so you know, Cheryl and Kate, we will compile this all. We, meaning Kate Bennington, compiles them all for us. She will email those out, as well as then they are on our Canvas page. So if all of you want to go back and see what the recommendations were, you can always go back and find those as well. Again, our next session is going to be in November. That's painful to say, but it's going to be in November. And our amazing Kirsten will be presenting on movement and ASD. So if you've not registered, please take a minute to do that, as well as take a minute and complete our survey for today. Thank you all for joining. And see you in November.
Thank